Yeah, so CLL, SLL, I think we have to start with the name, right? Chronic lymphocytic leukemia, small lymphocytic lymphoma. And you'll often hear them, combined together, but rarely you'll see them kind of talked about separately. Chronic lymphocytic leukemia is often found in the blood. It's a leukemia process where we may see the actual lymphocytes in circulation in the peripheral blood. And so this can come about when you're getting your complete blood count tested at your local family practice provider from that standpoint, and the white blood cell count is elevated. Within that white blood cell count, it's actually a math problem, whereas we take different components and we add them together, that makes the total white blood cell count. And in CLL, the lymphocyte compartment, or that part of that equation, is actually elevated. And when we see that, we then look at different components of the CBC. And your provider may choose to do a specialized test called a flow cytometry, which basically takes your blood, and it's like a big gumball machine. And within that machine, you're dropping, each gumball is a lymphocyte. And it's actually asking the question, are all these lymphocytes the same color gumball, or are they different colors of gumballs kind of going through this big gumball machine? And if you see too many, let's say, red gumballs all in one, and they're flying the same flags that are identified through this big gumball flow cytometer machine, we call those monoclonal lymphocytes. And so they all have the same expression pattern. And in CLL, in the peripheral blood, that expression pattern is very uniform. And so often they're expressing flags like CD5, CD23, and there's an overwhelming preponderance of these same colored gumballs over and over again. And so that's a monoclonal B-cell lymphocytosis, right? Monoclonal, one color, lymphocytes, and cytosis just means that there are too many of them. Now, there's a precursor condition called monoclonal B-cell lymphocytosis, which I just spoke about. But if you get too many of those gumballs, that can become chronic lymphocytic leukemia. Now, take that disorder and move it outside of the blood and put it into the lymph nodes. So lymph nodes are, think of it, we're here in New York City. Think of your lymphatic system like the subway system, right? You have different lines, the 3, the 4, the 5, the 6. Think of those as different stations of where these lymphocytes can basically get off the train and congregate, all right? And that becomes what a lymph node is. You see too many of these same colored gumballs or lymphocytes kind of sitting in a station, and it overwhelms that station. So it's just jam-packed full of these same colored gumballs. And that leads to enlargement of those lymph nodes. So if you did a biopsy of a lymph node, whether or not you take a thin sliver, which is called a core needle biopsy, or you actually remove the entire lymph node, called an incisional or excisional biopsy, what the pathologist will then see under the microscope is all of those same colored gumballs. So the same gumballs that are in the peripheral blood, sometimes called chronic lymphocytic leukemia. If you do a biopsy of a lymph node, you'll see the same phenotype or the same flags being expressed on those lymphocytes in the lymph node. And so dependent upon where a biopsy is done, you get chronic lymphocytic leukemia if it's in the blood or the bone marrow, or small lymphocytic lymphoma if you do it in the lymph node. And so really, I think there's a lot of confusion. There's often a slash in CLL, SLL. I try to explain to my patients that they live on a spectrum. Some people will just manifest as chronic lymphocytic leukemia with a small lymphocytic lymphoma component, or you'll see the exact opposite. Well, they'll have kind of small burden lymphadenopathy with very minimal to no blood involvement. But over time, as the disease kind of proliferates and exists longer than it should, both compartments often rise up as a manifestation of the disease spectrum. Most often, CLL/SLL presents with an asymptomatic feature, meaning that we are finding this, incidentally. We're finding it at your Medicare physical. Welcome to Medicare. Here's some blood, and we see that elevated white blood cell count. Again, then going down and looking at the components of why that white blood cell count is elevated. For patients that may present with lymphadenopathy, often the lymph nodes, again, kind of those areas that we can palpate, like in the neck, underneath the arms, or in the growing region, may be the initial reason for the person to come to the primary care provider to be assessed. They thinking that they had a viral infection, a sore throat, they got a vaccine, that we now know can lead to kind of lymph node enlargement, and then but the lymph nodes in response to an infection are supposed to enlarge appropriately, because that's a manifestation of the immune system working. But over time, those lymph nodes should go back down. But in CLL, SLL, those lymph nodes often stay the same. That then leads to those lymph node swelling to affect buttoning your shirt, can impact how it feels underneath the arm, so it can just be some positional problems. But what we can't see is the middle of the body, right? So deep down below, I still don't have my radiation glasses yet to kind of instantaneously put them on and see what's going on inside the body. So sometimes we have to use other imaging modalities to see where the lymph nodes and how enlarged they are from a SLL or small lymphocytic lymphoma component that may be causing just a chronic cough if it's sitting behind the trachea. And very, 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 that's a lot of varies, rarely do you see lymph nodes that are trying to impinge upon, and cause end organ damage or organ damage in general. Typically, obstructing the flow of the liver or bile from the liver, as well as obstructing flow of urine from the kidney to the bladder. But in an indolent disease like CLL, SLL, this is more of a disease of just occupying space, so a space occupying lesion, rather than some of our more aggressive lymphomas, which will not only occupy space, but will try and strangulate those areas. And so that can often be some of the presenting signs. It's just general lymphadenopathy. Now, what's unique to CLL, SLL is actually that it can cause splenomegaly. So the spleen, think of it as a big lymph node, okay? And through embryology, right, when we were in the womb and our immune systems were being made, it starts in the liver, moves to the spleen, and then goes to the bone marrow. Now, think about this as we get older, right? Our bodies are very intelligent. When CLL starts to infiltrate into the bone marrow and starts to crowd out space, what often happens is that the body's very smart and it remembers. It can remember all the way back 67 years ago, when you were in utero, and it'll say, the bone marrow's getting occupied. Where else can I make red blood cells, platelets, and other bits of the immune system when other areas are being crowded out? It goes back to the spleen. It can go back to the liver. Okay, so those areas will remember that it can make other parts of the immune system there. And that enlargement will come from that aspect of trying to balance that hematogenesis of other components of the immune system. But the CLL cells are also smart, right? They know that they can occupy that space too. And so what you will sometimes see over time is splenomegaly, or enlargement of the spleen, but also hepatomegaly, which is enlargement of the liver, as a manifestation of kind of progression of CLL, SLL. As I alluded to earlier, kind of in a longer discussion, often CLL, SLL is diagnosed via that flow cytometer machine, that big gumball machine where you're basically popping peripheral blood in and then keying in on a very focused component of that lymphocyte component of the gumball machine, and then asking the question, are those gumballs all the same color? And really, it's a math equation, okay? You're actually looking for the number of lymphocytes that all are the same color compared to the all other components of the rainbow. So if you think about the rainbow and all of its different primary colors, you're going to see lymphocytes that are yellow and blue and green, but there will be an overwhelming preponderance of red, of those red lymphocytes that will be kind of channeled out through that flow cytometer gumball machine. And if the math equation equates to more than 5,000 monoclonal lymphocytes, then that kind of reaches that or passes that threshold, which takes us from monoclonal B-cell lymphocytosis to a diagnosis of chronic lymphocytic leukemia. Now, as discussed, you can also come to the diagnosis through a different pathway, which is through a lymph node biopsy or even a bone marrow biopsy if there are antecedent low blood counts that drive the reason to do a bone marrow, or enlargement of the lymph nodes that lead to a biopsy that may render a diagnosis of small lymphocytic lymphoma. Again, so where the tissue is retrieved from can lead you down two different paths, which sometimes can be incredibly confusing to patients, because on one hand, they're told they have chronic lymphocytic leukemia, but then they feel lymph nodes, and they're like, what is this? And I just tell them they have lumpy, bumpy CLL, right? And that's just part of the spectrum of CLL, SLL. Yeah, this has been a disease that's been turned upside down in regards to how we used to treat CLL, SLL to how we now treat CLL, SLL. But in the now treatment era, we are still struggling to kind of figure out who and how we need to treat and with what. And so if you reflect back, even about 15 years ago, we were still using chemoimmunotherapy, which was very effective at dampening the ability of CLL, SLL cells to persist as well as proliferate. But now we've really moved into more of a targeted approach on how to target these CLL, SLL cells. I often think of this as a lymphopersistence disorder, meaning that these old B cells are just hanging out in the body too long. They will slowly proliferate, but they will persist long beyond their lifespan. Okay, so they're just occupying space either in the blood, in the bone marrow, other organs like the spleen or the liver, or even in the lymph nodes. And so over time, they just persist longer, but they still have a proliferative component to it. And so when we're thinking about when we need to treat CLL, SLL, and then how to treat it, I think if you meet an indication for therapy, then you are actually going down two paths, because chemoimmunotherapy really has been shoved to the side, and it's been shoved to the side appropriately through prospective randomized clinical trials, right? The creme de la creme of the things that we should do to say, okay, chemotherapy, move to the side, you're no longer needed, or you're needed later on in the treatment and management of CLL. And now we've moved to these targeted therapies, but the targeted therapies have been bucketed into continuous therapies, like with our covalent Bruton's tyrosine kinase inhibitors. Some of those, our first generation was ibrutinib, which we all kind of grew up on and learning how to use with some of its unique class side effects, to second generation covalent BTKs, which are acalabrutinib and zanubrutinib. So again, covalent BTKs, I would call them second generation BTK inhibitors. But in that strategy, it was a continuous dosing strategy, meaning that you were on that therapy until it stopped working. You had a toxicity that basically said, this isn't the right drug for you any longer, or you came to your care team and says, I just don't want to take this pill any longer. And then there's actually now fixed duration strategies, which are using a different class of drug called a BCL2 inhibitor. Namely, the first generation of that is venetoclax, which is actually kind of pushes those CLL cells to the precipice of falling off the cliff that makes them no longer want to hang out and persist. And so they're now going, off that cliff and dying. But with venetoclax, in order for it to be a fixed duration strategy, it has to bring an old partner with it, a CD20 monoclonal antibody. And this, in this case, is called obinutuzumab. And that's a very powerful monoclonal antibody targeted against CD20. Many of you may have heard of its stepbrother, rituximab, which has now been around for decades in the management of not only CLL, but also other non-Hodgkin's lymphomas. But if you're doing a fixed duration approach in the frontline setting, often we're employing venetoclax and obinutuzumab. Now, to make it even more confusing, we now have clinical research in the frontline setting that's saying, well, maybe we can borrow these first generation BTKs or second generation BTKs, and let's add them to venetoclax and obinutuzumab, but in a fixed duration approach where we're now using techniques like minimal residual disease assessment, which is really kind of going into either by putting the blood back into that big gumball machine and saying, okay, we're looking for reds, but we're going to count 100,000 gumballs or even 1 million gumballs, and we'll see how many of those specifically red-hued gumballs that we see, and if we don't see them, then it's undetectable, right? And so that may risk adapt whether or not we continue that therapy or we stop that therapy, or we just say, It's January 1st we started that therapy, and January 1st the next year, or depending upon the clinical trial, 2 years from now, depending upon where you're at in your CLL landscape, because the calendar turned to that next year, we're done, with this therapy, and we see how long it takes for those CLL cells to build back, within the body. And the hope is that with that, bringing those two novel classes together, sprinkling a little CD20 on top, that we can get years. I'm hoping for years if you move down that strategy rather than months. And then, if you get years, perhaps you can just recycle the same regimen and get, even similar amounts of years. But I think in the landscape of oncology, often what we see, and we're trying to find, this data, because CLL has a very long runway of its disease, of the law of diminishing returns, right? In oncology, we often see that in the chemotherapy realm, but we really don't know about that law of diminishing returns in the CLL landscape. So often you can, postulate that you could recycle these therapies, but because people are having such long remissions, it takes even longer to generate that data. So it's a great problem to have when you have very effective therapies, but also we're not very patient people in oncology. And sometimes you do a trial that I plan, I'm 44 years old, my 21-year-old may be the one that gets to publish that, because that's how much success we've had in the management of CLL, SLL, that really to have those events, you're really talking about, years, sometimes decades, to see the outcome of that research. And so with the progress that we've made, has come a reset of us having to be patient in order to how the field will evolve. Relapsed refractory CLL has kind of also gone through iterations of change, and those iterations of change really come back to what you did in the frontline setting. So if you were on a continuous strategy, let's say you're on a continuous covalent BTK inhibitor, which we talked about, which could be ibrutinib, it could be calibrutinib, it could be zanubrutinib, different brutinibs that are coming through the clinical trial pipeline. If you progress through that continuous therapy, then often I will roll patients over to a second-line BCL2 inhibitor with venetoclax. I have often substituted obinutuzumab instead of rituximab. I know everybody, it's the Murano trial. It was venetoclax, rituximab in the relapsed refractory CLL disease landscape. But I just think that obinutuzumab is a better CD20 monoclonal antibody specifically for CLL rather than rituximab. So I'll use the newer kid on the block in that relapsed refractory CLL space. Now, flip the script, right, and say, well, what if I had used time-limited therapy with venetoclax obinutuzumab in the frontline setting? Well, then I get to ask myself the question, well, how long was that remission duration to that fixed duration therapy? Because I could go back and, for the sake of a clinical trial, which is important, I could deem revenge again on the CLL with the same regimen if it had been long enough. Now, we don't have a lot of data to say, how well that second line of the same thing that you used in the first line will work out, but I think it's a reasonable discussion to have. Or I could pivot to using a covalent BTK inhibitor again, but I may do it in a continuous duration strategy, or I may recruit that venetoclax and CD20 antibody with that continuous BTK inhibitor to make that second line strategy once again a fixed duration strategy. And so really, we are weighing kind of continuous strategies to fixed duration strategies, often through the auspices of clinical trials. And I think the way to continue to move the field forward continues to be, being willing, where there are very good and well-planned clinical trials, which we've done an amazing job, not only through industry-sponsored research, but also through the cooperative group mechanism of moving the CLL landscape forward. Yeah, so even if as you're moving past the front line, the second line, and getting into the multiple relapse refractory CLL space, and as I alluded to, CLL is not a sprint diagnosis, it is truly a marathon. The nice thing about figuring out kind of where you're at in that journey of a marathon is trying to check the mile marker. And sometimes the disease, will speed up, and you always have to be aware of what we call Richter's transformation, which is where CLL, SLL will morph into a more aggressive variant called diffuse large B-cell lymphoma. And I think that as a lymphoma specialist, you always need to keep in mind, is this CLL behaving differently? Because you do not want to miss a transformative CLL into a Richter's transformation, because that is a prognosis-changing event many times, and you need to potentially do something different. And so I put that out there as an educational piece to the patients to be their own advocates, right? If there is a lymph node that is growing unlike the others, I call it my Sesame Street lymph node, which one of these is not like the other, that may be the first signal that there's a transition or a change in the gear of your CLL, and you should bring that to the attention to your care team, because that would require immediate attention. Now, kind of taking that situation out of the equation and talking about your CLL, SLL, when there is no evidence of transformation in the relapse refractory setting, we now are moving into the era of CAR T-cell therapy in CLL, SLL. Lysocell, which is a CD19-directed CAR, has been specifically studied in the relapse refractory CLL space. I think it's going to find its niche for those patients who are refractory to a BTK inhibitor, as well refractory to a BCL2 inhibitor. Now, there are non-covalent BTK inhibitors that have also been developed, namely pirtobrutinib, with other non-covalent BTKs kind of coming down the pike. Pirtobrutinib, I think, does have a space after refractory or intolerant to a covalent BTK. And I kind of explain this to my patients like you're at a hotel, and back in the olden days when you used to get the key to stick into the doorknob and turn the key, think of that like covalent BTK inhibitors, right? But now your CLL has garnered a mutation that essentially the CLL has broken the key off in the door handle. Now with pirtobrutinib or the non-covalent BTKs, they're like the key card. You just have to walk up to that handle, and you may have the key still broken off in that handle, but now the disease is able to be controlled by the key card rather than a physical key that allows you to open the door to eradicating that or controlling that CLL, SLL clone that may be causing problems. So that's pirtobrutinib. You now have Lysocell, the CD19 CAR T-cell, which is essentially a very effective therapy that we've seen kind of march through more aggressive lymphomas like large B-cell lymphoma to mantle cell lymphoma to follicular lymphoma, and now I think achieving success in CLL, SLL. I know the prospective studies, we really didn't get a lot out in the clinical trials, but you have to remember in the clinical trials for CLL, SLL, for CAR T-cell, median line of therapy was 5, right? That's a heavily pre-treated population. A lot of those patients were probably not treated the way we would treat them 5 years ago, right? With a lot of them had received chemoimmunotherapy because they were on the marathon sprint, right? They were in the disease landscape. They were at mile 19, 20, from their standpoint. And so I would argue that in the real world experience, so what we'll see with CLL, SLL in regards to CAR T-cell, that this will be one of those paradigm changing shifts where I expect the real world data to actually look better than the clinical trial data. And that's often not seen when we look at other real world experiences in other types of lymphoma. That's just me kind of putting and looking into my muddy crystal ball in regards to where I see kind of CAR T-cell in this space. There are other novel mechanisms that are being studied, BTK degraders, which is kind of like throwing that BTK protein, that Bruton-tyrosine protein, into the garbage disposal, right? So it's like flipping the switch and grabbing a hold of those BTK proteins and shooting them through the garbage disposal. And if that mechanism allows for such that the BTK protein is inactive, that leads to the inability for those CLL cells to persist and hopefully proliferate, and numerous other classes that are coming down the pike for the management of relapsed refractory CLL. So it's a good chaotic space right now where the data is always in evolution, but so are our brains, and that kind of what keeps it interesting. Yeah, so that's a great question, because the nice thing about CLL, SLL is that very, very rarely are you walking into an oncologist room with a newly diagnosed CLL, SLL, and the next discussion is that we need to cross the bridge of treatment, right? So you often can be patient and be very discerning as a patient to think about when you need treatment. And as a treating CLL, SLL doctor, you also have to be patient to try to learn the tempo and the pace of the disease. The nice thing about CLL, SLL is it often gives you the opportunity to be patient. Now, it does have its unique features to it. You know, CLL, SLL can manifest as autoimmune hemolytic anemia. It can manifest itself as idiopathic or immune-based thrombocytopenia. So people can present with these autoimmune conditions that you may need to treat the autoimmune condition and not necessarily treat the CLL. But sometimes if you're refractory to the management of those autoimmune conditions, you need to kind of take away the CLL in the background. Other reasons to treat CLL can be those lymph nodes are enlarging to cause quality of life issues. You know, if you look like a linebacker for the New York Giants, you know, because those lymph nodes are getting so big and they're causing pain or discomfort, that can be an indication for therapy. Also, if those lymph nodes are starting to encroach upon, you know, different areas to try to obstruct or cause problems. If the spleen is getting large enough where it's starting to encroach upon that paper sac, that thing we call the stomach, really it's taking up real estate, so now the stomach can't expand. That's called early satiety. So I like to eat a 6-inch sandwich, but I get to the 3 inches of that 6-inch sandwich and I'm like, I'm full. You know, that's can be an indication for therapy. And then also cytopenias. Again, we talked about that CLL can occupy the bone marrow, crowding out the ability of the bone marrow to make hemoglobin or red blood cells. Okay, that's called anemia. And then also the ability to make platelets or thrombocytopenia. And platelets are kind of the fish that initially plug the holes if you were to cut yourself. And so low platelets, low hemoglobin or red blood cell counts may also be indications for therapy. One of the hard to discern indications for therapy is constitutional symptoms. So fatigue, right? And that's often the hardest indication because often, you know, living life sometimes is just tiring, right? The way I try to explain fatigue to my patients is at the end of the day, you can be tired, but then, you know, by the next morning, are you recharged, right? Or are you still tired when you get up? And if you can prove that there's no other, you know, there's not sleep apnea, you're not hypothyroid, there's not other medical conditions that can be causing your fatigue, and you know, there's no really other indication for CLL, you have a heart-to-heart discussion about, well, I can treat your CLL. I may improve your fatigue, or your fatigue may stay the same because your CLL is likely going to improve with our therapies, but sometimes my medicines can cause fatigue too. So you have to kind of have that trade-off situation. But many times I've treated people for other indications and they said, I didn't know how tired I actually was until I treated my CLL for anemia or thrombocytopenia. And now they're kind of a new person in regards to you just turn their AAA battery reserve into a AA. You know, you gave them more bandwidth for their Energizer Daily Bunny. CLL, SLL is like an accordion, right? When I talk to my patients about how often they should be seen. You know, when I have a good understanding of their disease pace, we've had time to kind of monitor it, I may extend those visits out to twice a year, sometimes rarely once a year based upon kind of what I understand of their patient's disease. But I'm also advocating for the patients to be their own musician here, right? So if they start to have symptoms, they need to call in and we need to shorten those visits. Or I may see changes on their blood work that may make me go, well, we were seeing you every 6 months. Now I want to understand better because there may be, you know, your disease may be changing gears. So I may want to see you in 3 months, all right? And then I understand that it plateaus again, we go back to 6 months. So I'm really looking at Maybe not so much the lymphocyte doubling time. So the white blood cell, specifically the lymphocyte, if it goes from 15,000 to 30,000, if it does that in 3 months, it should get my antennas up again. But then I'm also looking at what's the hemoglobin doing? What's the platelet count doing? Because often what you'll see is, if you think about it just visually as a graph, as the hemoglobin and the platelets go down, the white count or the lymphocyte count often goes up, and they bisect over time with the x-axis being time. And so usually they go hand in hand, but I often use the hemoglobin value, the platelet value, as well as the constitutional symptoms of the patient to help gauge not only when they need treatment, but how often I see them. And having that discussion up front can help the patient understand, just how often and how impactful this will be to their life. But I also want to ensure that I'm empowering the patient, that if they're on a 6-month cadence of seeing me and my team, that they're also able to pick up the phone and say, something's just not right, right? We talked about those Sesame Street lymph nodes. We also talk about just, I'm not feeling right, 4 days in a row, right? This isn't a virus. This isn't something else that happened in my life. It may not be your CLL, SLL. It may be something else, but empowering them to pick up the phone and say, I think I need to be seen earlier. And that's never a wrong answer. And I don't use that word never very often, because always and never are two words that are hard to have in your vernacular. But I think in CLL, SLL, empowering your patients to feel that they can be their own advocate to being seen sooner, or at least having their labs checked sooner, because you don't want to miss that opportunity to intervene earlier in this disease landscape if necessary.